Good afternoon, everyone, and welcome to the 2024 annual lecture of the Cambridge Centre for Health Services Research. I'm John Sussex, and I'm one of the two co-directors of the Cambridge Centre, along with my colleague, Professor Steve Morris from the University of Cambridge. I'm at RAND Europe and a senior member of the Health Services Research team there. And Steve is the RAND Professor of Health Services at the University of Cambridge. CCHSR itself is a collaboration between the university and RAND Europe, which has been running now for 15 years. And each year we do an annual lecture, and welcome to today's. So Steve and I are absolutely delighted to be inviting to lecture today Professor Claire Jackson from University of Queensland. And she'll be talking to us about her question: is primary care reform the solution to imploding healthcare systems? I'll introduce Claire properly in a moment. But first, there's a little bit of housekeeping, tiny amount. First thing is to say, we are going to be recording today's lecture, which means that there will be slides and a summary of it available on the CCHSR website after the lecture. As your sound and video have been disabled, there will be no breaches of your confidentiality, I hope, but please note that your name will appear in the participant list down the right-hand side, so other people will be able to see that you've been in the audience for the call. If that bothers you, you might want to change your name in your under your Zoom icon, but I hope that doesn't bother you. Anyway, Steve will be chairing a Q&A session at the end of the lecture, and we're going to leave plenty of time for that. But what I'd like to do now is to properly introduce Claire. So, Claire, welcome. Thank you very much for doing this year's annual lecture.
Thank you very much for having me.
Claire is a professor in general practice and primary care reform at the University of Queensland in Australia. And she's the director there of the Centre for Health System Reform and Integration. Perhaps rather more importantly, for us being selfish, is that she has for many years been a major contributor to the healthcare reform and strategy discussions that have gone on in Australia, and many of you will know that those have been very active. They've been every bit as active as the equivalent strategy and reform discussions in the UK over the last couple of decades. And her prominent role was recognised in 2021 when Claire was made a member of the Order of Australia for services to primary health reform and to general practice medicine. And she's been a past chair and president of the Royal Australian College of General Practitioners. So as you can tell, we are in excellent hands. So Claire, over to you, and looking forward to it.
Thank you very much. And thank you so much, John and Steve, for the opportunity to be part of today's presentation. I'm just going to pull my PowerPoint up now, so please bear with me. There we are. You should be able to see it now. Is that coming through well?
We're not seeing it at the moment.
Okay, one moment. Let me try that again.
That allows me to say something, John, that I forgot, which is that if you wish to put in a question to Claire, use the Q&A function at the bottom of Zoom, not the chat. The chat is disabled, but please use the Q&A function.
All righty, I think we're close to there. I won't be a second. I'll just minimize that. All right, so to start at the beginning again, thank you very much, John, Steve, and the team at the Centre for putting up with me over my sabbatical, but also in assisting with choosing the topic for today's lecture. Addressing imploding healthcare systems, is primary care reform really the answer? So, as you've heard, I'm a long-term healthcare reform protagonist, and I've approached today's presentation from many perspectives. First of all, as a clinician, I've been in active general practice for 40 years now. I started in a small rural community in the outback, where, as well as humans, I treated my fair share of sheep, cattle, and kangaroos. I've been an active consumer both in urban and rural settings of healthcare for a long time. I have had 3 children who are now thankfully in their 30s, and I was the primary carer for my frail elderly parents in the sunset of their lives. About 5 to 10 years into my time as a general practitioner, then in urban Brisbane, I became very frustrated by the way the healthcare system got in the way of my patient and myself making the best decisions and accessing the best care. And I became very interested in health services research and started a parallel career there. And then, as John said, the opportunity to be chair and then president of our Royal Australian College of General Practitioners really allowed me to advocate for primary care and healthcare reform as a whole. In the last 15 years, my health services research approach has led much more to innovative models of care and becoming an active protagonist with healthcare delivery. And I think through all of this, finally, I've become much more pragmatic around what is possible within healthcare reform and how very long it takes to move even a small cog in the wheel. And most importantly, I'd like to think that I've become an agent of change for the best possible healthcare for my community. So 5 years ago, we combined our two centres of research excellence into one, the Centre for Healthcare System Reform and Integration, and we're funded jointly by the University of Queensland, our state government, and the Mater Research Institute, which is part of the Mater hospital chain across our state. It's a huge tertiary hospital, very interested in innovation, research and training. And our centre partners to research, evaluate and train in emerging areas of health system reform internationally. And in doing that, we form long-term partnerships with key stakeholders in health service delivery. Together, we spot the wicked problems and we share them. And then our centre takes a value co-creation approach with all the relevant stakeholders to deeply understand the problem, to address it, to together innovate around potential solutions, and then to appropriately evaluate those new approaches to care across quintuple aim. And funding and translation of our research with our centre is an agreed outcome with all those stakeholders. All of you will be familiar with Don Berwick's triple aim, which really made us sit up and look at the way we deliver our healthcare systems in 2008. In 2014, Tom Bodenheimer from UCSF added another aim, addressing clinician burnout. And more recently, JAMA in 2022 published some work from IHI, which added advancing health equity to those 5 key aims for a high-quality healthcare system. So to now focus on today's topic, are we noticing that international healthcare reform is really lots of talk, but little effective action at the patient level? And I'd like to look at the enormous amount of reform that's been occurring even over the last decade in just 4 countries with which we work closely. The UK's launched its 5-year forward view, the creation of primary care networks across the UK, and the Health and Care Act several years ago really shook up and reformed yet again the UK's approach to care. New Zealand led the way with organised primary health care through their primary health organisations nearly 30 years ago, which linked as a critical mass all primary care providers over a certain population. And more recently, New Zealand has merged its 20 district health boards into 4 regions, for which the reform is still falling out. The USA, through Obamacare, launched accountable care organisations and the patient-centred medical home, which is also prevalent in Canada, where patients had in the community a healthcare home that would be responsible for their care, offer proactive as well as reactive care, and most importantly, continuity of care with their patients and families. And in Australia, I was privileged to be part of the task force that developed our primary care 10-year plan, which was launched in March 2022. And then with a change of government in May 2022, we've had 5 strengthening Medicare inquiries that are now just reporting. So I would put to you that we've had primary care-led reform rhetoric well and truly around since Alma-Ata in 1978, repeatedly calling out the relevance, resourcing reform, and the need for much better integration and accountability of the sector. and that to include whole of system planning, funding and service reform, a focus on prevention, early diagnosis and intervention, and chronic care close to home, as well as impact of frailty. And we've also looked and called for stronger integration between acute, community and social care sectors, and more recently, including innovative use of digital health. I'm going to spend no time at all on the long-term evidence for the better, for stronger and better integrated primary care, because we've been talking about this since Barbara Starfield first launched her paper, Contribution of Primary Care to Health Systems and Health. I've included there just a couple of other of the scores of different reports and presentations and recommendations that have occurred over the last 20 years, including the World Health Organization and UNICEF statement on the vision for primary healthcare in the 21st century, the US Academies there in the right-hand side, implementing high-quality primary care, rebuilding the foundation of healthcare, which was launched in Washington 2 years ago, and again at the Thought Leaders meeting last year. I've included a couple of our Australian publications, the 10-year plan there, but a beautiful one from Consumer Health Forum called Snakes and Ladders, the real journey of patients in the Australian healthcare system. And right at the back there, one of, I think, the best articles demonstrating the impact of high quality primary care from Yang, Bazemore, Phillips et al. 2 years ago, where they looked at the impact of physician and practice level primary care continuity on all 5 quintuple aims and the enormous benefits that accrued across 1 million Medicare beneficiaries. Yet despite all of that, we have growing evidence not just of health system dysfunction, but of absolute implosion. We have a rapidly increasing chronic and complex disease burden with the prevalence of obesity, particularly now, that becomes more and more dire over the years. That leads to very much increased difficulty with giving people access to the most appropriate care and resourcing the additional care that's required. We're seeing increasing burnout and workforce dysfunction across the board. And sadly, over the past 20 years, the continuity of care model, which we have so depended upon to deliver high quality care efficiently and at the point of access, has decreased enormously. The US now estimate that over 50% of the resources required in healthcare, the human and fiscal, are related to unhealthy lifestyle choices, particularly obesity, drug and alcohol abuse. And we are noticing, despite all of that, ever-increasing compliance to service providers, to healthcare organisations, and growing dissatisfaction, particularly with patients and the community around that. And finally, particularly in the UK, we're witnessing extremely increased negativity towards the health sector, particularly in the popular media, but often in social media also. Well, where are we now? I would suggest that we are overwhelmed and on crisis management at almost every level. Post-COVID, we're also sadly cash-strapped. And very much a feature of the last 10 years, we're trapped in our political cycles where one lot of reform is overtaken with another lot of reform, which is overtaken by further inquiries with changes in government or changes in political direction. And in the middle of all of this, primary care, which is supposed to be leading our healthcare reform, is dying. It has a hugely expanded demand, especially during, but also post-COVID, and is now a very complex care environment. It's poorly valued and remunerated and very little understood. The workforce is rapidly diminishing. Now, rather than 50% of new medical graduates going into primary care or general practice training, we're lucky to get 10 to 15%. And we're plugging that with new roles that definitely reduce continuity of care, but also increase the care complexity at the practice level with new roles of supervision and requirements in training. Meantime, traditional cultures and institutions outside primary care have proven highly resistant to reform, and we're noticing increasing inequity in many OECD countries between primary care and secondary care in terms of their influence, their remuneration and conditions. And although the Commonwealth Fund Mirror Mirror report consistently rates Australia #1 for healthcare outcomes, mostly due to its traditionally equitable, accessible, high-quality primary care delivery, we worry at home how much longer that can continue, as now nearly 50% of primary care delivery in general practice is user paid. But I'm a glass half full kind of gal. So what are the opportunities and solutions that lie out there for us to really take the stalemate we find ourselves in and move things forward? Well, first of all, we have the roadmaps. We have scores of them. We just find them impossible to follow. Also, no, I don't think there's anyone in the lay media, political parties, in clinician land that aren't supportive that we must change. We need to move our healthcare systems into contemporary times. And as the Kiwis would say, we are well and truly on a burning platform. I'd like to propose in this presentation that there are 6 colossal barriers that underlie the difficulty we find in implementing reform internationally. They're the huge part of the iceberg that sits below the surface, unseen, but the most dangerous of all. The first one is courage. To institute the sort of healthcare reform that's required to rescue our healthcare systems is huge. And it takes very big shoulder pads to take that on, understanding the criticism that will occur, the fact that we will go backwards before we go forwards, and that there will be large and very powerful organisations that will throw significant mud at those who try to change their power and territory. So it's not surprising that the political class, and often those who are in charge of budgets and in charge of deliverables, are very anxious about undertaking the very reform we talk insistently about and know we must implement to rescue our healthcare systems. The second one is resourcing. Let's be bold and call it cash. And post-COVID particularly, we are all stumped for cash and desperately trying to look at how we fund very expensive sectors in government, particularly health. We have small numbers of wonderful champions locally that do innovative and fantastic things on small amounts of short-term funding. They change the world as they know it, and then the funding disappears, all that work goes to naught, and people become jaded and sure that they won't try that again because it burnt resources, time, and a lot of good people. The other thing that is really much more apparent in the last few years is churn. Those who are implementing policy or designing policy turn over all the time. I interviewed a GP last month as part of my sabbatical work who said that not only is he dealing with a change once in 12 months with the executive and others driving reform, but they may occur 3 times in 12 months. And those people spend all their time coming up to speed before they move inevitably, and the reform that's planned falls back another 6 months to 12 months. We've got enormous change we need to implement, and yet we have no change management strategy or resources. As another GP said to me, I'd love to implement all this change, but while I have 10 patients waiting for me in the waiting room every session, I find it impossible to change the way I'm delivering my care. And finally, we can't just talk about it and say we're going to do it. We need to seriously commit to execute, and that means well-laid plans, KPIs, and people held accountable for what is expected. The consequences of those 6 barriers is that we find we are unable to reform hospital funding, power sharing, and integration with primary care. We have inefficiency and duplication rife as care fragmentation, overwhelming compliance and requirement for funding and support rain down upon everyone in the healthcare system, and managing the crisis today becomes the prevailing focus rather than building a system that's fit for the future. Primary care resourcing reform internationally has been an abject failure, and our healthcare workforce in general is demoralised and exhausted post-COVID. It's disrespected at every day and at every turn, and it's departing fast. Many healthcare workers are able to retire now in their mid-50s or early 60s. They're bright people, they're very well trained, and they're resourceful. And they are looking for joy in their everyday jobs, and they are moving to seek that elsewhere with great success. And finally, we have false and unachievable public messaging, raising inappropriate expectations, with our communities expecting Disneyland from our politicians and the political class, when really we need their help to turn our systems around, rather than complaining about the fact they are not as they have been promised. But glass half full, there's a lot we can do. And I think the first 2 points lie at the heart of enabling us to move forward. The first one is a real understanding of primary care, high quality primary care, the undifferentiated nature and the business model. When I first started as a GP registrar, my supervisor told me on day one that he hoped that the most important thing I would learn at the end of my 3 months is how to tell big sick from little sick. And I went home and I thought I'd got a lemon of a term. At the end of 3 months, I thought it was one of the wisest statements I'd ever heard. And I've written quite a lot about big sick and little sick since. The real truth is the diagnostic skill to be able to find the needles in the haystack amidst primary care is extraordinary. To be able to look at all those viral gastros and pick the patient with retrocecal appendicitis, to look at all those people with indigestion and nausea and pick the one with undifferentiated chronic kidney failure, the one who's pregnant, the person who's got alcohol and drug abuse, the person who may have stomach cancer, or to look at all those children with recurrent viral urtes and pick the one with acute lymphoblastic leukemia. That's the way you intervene in a high quality system and really appropriately diagnose and manage people, get them back to good health, and have the minimum reliant on expensive and very challenging secondary and tertiary care. The second thing is the business model for primary care, particularly general practice or family physician care, via its history, is often funded differently. It doesn't fall down the long line of state funding or federal funding, and often it has a small business model. That instantly makes those who fund anxious about what will be done with the money, and often distrustful about an organisation or a structure they can't completely control. A very good example of this was during the COVID epidemic in Australia. We were lucky enough to have Professor Michael Kidd, a very well-known and regarded general practice academic, accept the job on the 11th of March to be Deputy Secretary of the COVID response team. He was able to carry the torch for primary care as being mission critical to deliver our response, and include 7,000 general practices in the innovative, flexible, small community delivery of vaccination, care in the home, messaging and service delivery that really allowed us to offer the best quality COVID care as well as business as usual. And that leads to the next point, a real understanding of practice teamwork. Those small business models are very much focused on their own community and their demand and need. And that's very different for me if I'm practicing in Brisbane, or if I'm practicing in Bamaga, or if I'm practicing in the Outback. I might need an Indigenous healthcare worker. I might need a team coach. If I'm looking after a very high elderly demographic, I might need a social worker. My practice team needs to be focused on the need and our community and making that linkage work, not a cookie cutter approach with given a part of a person who might be useful. And those things lead us to really trusting and valuing primary care's critical role in a functional healthcare system. It's right at the ground level, the central building block, not an accessory extra that might be nice if you had some extra funding. And if we did all of that, we would surely have a joined up whole of system roadmap, with general practice doing the whole of the heavy lifting at the centre, and then building a system around that. That would allow us to commit to appropriately resourcing, integrating, and allowing local and flexible innovation across our health system. It would allow a mandate to execute with shared power structures, primary and secondary care, community groups, Indigenous and First Nations people, all sharing in the delivery of healthcare policy structures, with heavy clinician input and oversight from those who really know the real enablers and barriers at the patient level, and key performance indicators that are pragmatic, achievable and met, rather than pie-in-the-sky promises that will never be delivered. And wouldn't it be wonderful to have a 10-year direction that was supported by all? Some of that is a long term coming, but there are a number of things that we could possibly start right now. And the first one is to value and empower the healthcare workforce to reform rather than just giving them more tasks. And this was embodied in the work done in Canterbury in New Zealand just prior to the workforce, when every healthcare worker, whether they were on the wards, in the kitchen, whether they are in the primary care workforce, was asked what they thought would really improve the efficiency and deliverables in their particular part of the Canterbury Health District. And from that, they built an integrated force that reduced hospitalisations, greatly reduced their healthcare spend, massively invested in community, Maori and primary care, and delivered something that was quite extraordinary. We also need to refocus on our public messaging. We can't just bag people, bag hospitals, bag clinicians, publicly shame them if they don't get things right. It's a terribly complex, under-resourced and challenged environment that those great people work in. They should be celebrated for that rather than made a kicking bag, as one of my interviewees described themselves at the moment. And the other thing, we need good bureaucrats and advocates in place over time. I did some work in Ontario many years ago. They were pulsing forward with integrated care reform at a pace I had never seen before. They had their key bureaucrats locked in for a 3-year deliverable timeframe, and no one changed over that time. I became convinced that was one of the key success factors in their integrated care program. And finally, we have wonderful governance examples out there, if only we could embrace them and scale them. First of all, alliance contracting or alliance governance in New Zealand has been part of their healthcare system for well over 15 years now. And that's where the wicked problems at population health level are identified by all the key health service deliverers. Together, they enter a contract and set deliverables and funding collectively to deliver on that. And they all work together to help each other to deliver the output, whether they are small contracts or large contractor in terms of funding. And often the very large funders will put huge amounts of funding into the small organisations that have the best reach and the best opportunity for success. In the USA, people like Bob Phillips have been working for many years to convince state governments to proportion between 10 and 15% of their health budget primarily to primary care. And mostly that's Medicare and Medicaid populations. Now, 15 of the 51 states put at least 10% of their health budget annually directly into primary care. And finally, here in the UK, at very small scale, primary care networks have worked with their local service delivery communities to do quite extraordinary things with very small pots of short-term money and local innovation. Sadly, that has not been picked up by the integrated care boards and systems, but there's a huge opportunity to build. So is primary care reform really the answer? Overwhelmingly, yes. Appropriately resourced, well integrated and inclusive system reform is the only way to deliver a sustainable, equitable, high quality, future-proofed healthcare system. So going back to our enablers, we have some solutions and we have some real opportunities, but we don't have much time. We need to find those consistent leaders and champions across sectors who can let go of the bar in the shallow end of the pool, as we say in Queensland, and together take action. Every small child in Queensland needs to learn how to swim, and it's one of the joys of being a parent at the end of swim school, where they all sit there with their bathing caps on, clinging on to the bar in the shallow end of the pool as they're asked to demonstrate their skills and confidence in being able to accomplish what they know they can do. But they're very frightened of letting go of that bar. It's very safe and secure. So they cling on until finally one person starts off and then another. And then finally, they all achieve their aim and are set to actually then become active and efficient swimmers. That's the sort of approach we need to take to get all those anxious and nervous Nellies who are in policy positions to actually just make it happen. We need to give hands-on primary and secondary care leaders a seat at the resourcing and policy table. They're the ones that know how we can quickly make fast wins and move forward efficiently and maximise the resourcing, scant though it is, that we have currently. We need to recognise the importance of downtime and support for the infrastructure of change management. And we must change the discourse politically, at health service level, and through the media from "this is amazing, please go and get some," to something more along the lines of "it's not pretty at the moment, but we're all in this together and we have to turn it around." We need to advocate and deliver on the reform agendas that we promise. And in doing so, we have to be inclusive of all those who will be delivering it and pragmatic around what we can deliver and the timeframes within. And we must stop this bureaucratic churn and obfuscation of constant move, which will forever make it impossible to implement high quality reform. It will take resources, but also it must empower primary care as a key component of the whole system and not just an optional extra that you might throw some dollars at if you have a bit left over on the 30th of June. And we must recognise that the wicked problems, mental and behavioural health, complex chronic disease, frailty, and the huge impost of unhealthy lifestyle and turning around and intervening in behavioural health all require a continuity of care model grounded in the community. And we must support both an increased but locally appropriate workforce with digital clinical support and practical local innovation and flexibility. In closing, I would like to thank Steve, John, and particularly Martin Rowland, with whom I've worked for many years, for your support during my sabbatical and your input to this presentation. And I'm delighted to announce that the International Healthcare Reform Conference and Thought Leaders meeting that was incepted in Washington over a decade ago and has moved to Australia and other countries will now actually come to Cambridge in July next year. We already have 12 of our thought leaders committed to lead sessions with us, and this is where we all come together to explore the evidence, to innovate, and to network closely with global thought leaders. Our keynotes are exemplars in what can be achieved despite the many barriers to reform, and will challenge and inspire us to influence change in our own sectors globally. So for those of you who are interested in joining us and contributing to that program, the email is freely available to you at the bottom of the screen. Finally, this is our burning platform moment. The Darcy report last month was chilling and leaves no doubt about the implications of further delay. Resourcing is essential, but so is focus and consistency. It's not just throwing extra dollars in, it's really looking at significant reform. The challenges are truly Herculean, but must be understood, confronted, and successfully addressed. And I believe a well-integrated national approach implemented via enabled local coalitions is at the essential core. Having a grand vision is no longer enough. A 3 to 5 year turnaround is realistic. And please, no more fiddling whilst Rome burns. I look forward to your comments and contributions for the second half of our hour, and thank you very much for the team at CCHSR for your support.
Thank you very much, Claire, for the excellent presentation. Very thought-provoking, very eye-opening, and I particularly liked the call for courage among thought leaders. That was very well put. So if I could remind colleagues on the call, if you would like to raise a question, please can you do so using the Q&A function. We have a few coming through so far, Claire, so without further ado,
Certainly.
We've had a question from Fraser Batty. Thank you, Fraser, about continuity of care, and that was something you mentioned several times in your talk. So Fraser asked, could you maybe say a little bit more about the value of continuity of care, particularly in primary care, and then whether the emphasis on access to care has been unhelpful?
Yeah, that's a fabulous question. And that's why I added there the very wicked problems we're dealing with that are really overwhelming the system and overwhelming us as practitioners, which are lifestyle intervention. Mental health and behavioural health is enormously complex, time-consuming, and often sits at the heart of chronic disease. 80% of people with chronic and complex disease have significant anxiety. Frailty is another growing, I won't say burden, but element of healthcare delivery. All those things require someone who has a relationship with the patient and is able to work with them over time. And trusting and understanding and having a relationship was one of those big issues that Yang looked at in his paper. And you think yourself, if you are obese, or if you have depression and anxiety, or if you have significant diabetes or heart failure, if you see a different person every time you go to have your review or a diagnostic or investigation review, then you never actually form that deep relationship which allows you to make very difficult decisions, particularly around lifestyle modification. I think what we've done is exactly as the question suggested, is because we want to find an extra 50,000 consultations somewhere in the system, we just plug other people in. We give people access to a person rather than a diagnosis or an ongoing management that's actually going to make a difference. So if we look at the outcome being change in weight or change in heart failure or reduction in blood sugars or improvement in hypertension or reduction in anxiety or depression, then that's a continuity of care model. I think episodic care is fine for a much smaller amount of the healthcare system now, where you have an episodic problem, you go to see someone and it's sorted. But so much of what we do in primary, secondary, and tertiary care now really, although it requires a team, requires one or two people who are those continuous, ongoing supports that you can tell everything to. You can be really honest about what you're doing and why you're not following care plans. That's the sort of thing that the evidence shows will have the biggest impact on our system, and we have to get it back.
That's excellent. Thanks very much, Claire. Very helpful. So now we have a question about the role of the health system in general, and whether, for example, there are countries which are more wedded to private healthcare systems are more likely to be able to reform their primary care services sooner or more effectively than countries with more nationalised systems. I wondered if you have your views on that, please.
Yeah, I mean, look, we've Australia sort of sits on the fence. We've got 50% of our population have private health insurance, which they use in various amounts for either community allied health, for direct access, or for hospitalisation. 63% of patients get their daycare surgery privately. Other countries such as the UK are very publicly focused. I don't think that's the big issue. I think it's actually having the policy levers that enable people to be as effective as they can be for their communities where they are. So that alliance governance, alliance contracting model, I've seen that work with publicly funded, privately funded, bilaterally funded. I think it's really allowing those structures that sit locally closest to their communities to actually be resourced to make a difference. And a lot of the interviews I've been doing lately, and certainly that mirrors the situation in Australia, is that people know what they can do. They absolutely know what is possible. The community organisations are crying out for change. It's just no one's allowing the resources or the flexibility to make that happen. And so my second final slide, where I looked at a nationally consistent system, but locally led and locally supported to be innovative. I think if you've got very scarce resources, that's your only way forward at the moment. And I would say definitely in the UK, but certainly in Oz, we're desperately trying to get that much more a feature of our healthcare reform service.
Very helpful, thank you. So we've had a few questions from colleagues on the call about the role of kind of policymakers and system leaders. So there's a couple here that you might want to take together. So, for example, Peter West says that he agrees that change needs empowerment at the local level, in particular. But how do we get politicians to let go? Be interesting to thought that. And then Martin Marshall asks, why do you think we find it so hard to persuade policymakers and system leaders of the veracity of the evidence from Barbara Starfield?
Yes. So I think what's going well for us is the burning platform. I mean, implosion is the description of what's happening. And certainly one of the number one voter issues in Australia is that voters are demanding their politicians actually bring back general practice. We've had a large number of practice closures because of the appalling funding. And we've now got enormous political momentum around recognising that. I think the policymakers often sit up in the helicopter and they don't see the grass below. They actually, what they design, sounds on the face of it, if you weren't at the coalface, to make good sense. But if you actually involve people who really work at that level currently, rather than maybe 10 or 20 years ago, they would rapidly unpick some of the implementation problems. So to give an example, we've just launched a My Medicare program 2 years ago from our federal government as part of that 10-year strategy, where every practice registers to be able to have their own practice register. People with complex chronic conditions or other things will register with the practice, and that should unlock some extra resources both for the patient and the practice. Sounds amazing. So the first group they took on board to do this would be residential aged care. Now, why in a million years would you choose that group? So never mind, they rolled on. So all those practices and others who are delivering residential aged care services all signed up in 6 weeks. That was 18 months ago. The policymakers have now decided what that's going to look like, and basically the funding for that wouldn't pay the petrol to actually visit the aged care facilities 12 times a year. And they haven't worked out that a large number of these people have dementia and won't be able to give consent. So now only 30% of the patients who currently are eligible for these services are able to receive them, because the structure of the policy implementation is just so devoid of any understanding of how the real world works. So having those jobbing GPs, I think you call them, or people who are at the hospital ED interface or outpatients or on the wards, really giving an idea about what should be part of the implementation plan, and most importantly, the timing that is absolutely mission critical to deliver these reforms, I think is probably the most important barrier at the moment.
Thank you very much. We have a question from Duncan Edwards about industrial action and
Yes.
anarchy in the system. English GPs began ongoing industrial action, obviously opposing things like centralisation, etc. Do you think that sort of strategy is the right way to go? Should there be a KPI for more anarchy, Duncan?
Yeah, I love that question. Thank you very much. I think multiple strategies is the way to go. And so I did talk about a coalition of the willing, people who are in government, politicians, policy makers at the highest level, executive managers, clinicians, consumers, and then the media. So to look at some of the changes that have been possible at home. First of all, is our college approached all sitting members nationally. We have nearly 300, and said basically general practices are closing their doors, which they were, or retiring early. It's a #1 voter issue. We need to do something collectively. We'd like to have a Friends of Primary Care, a Friends of GP bipartisan group. So we have a Green senator, we have an equivalent of a Tory, an equivalent of a Labor politician. Some of them are GPs, other than one's disabled, who they're constantly in the Parliament making the importance of primary care reform and healthcare reform present in everyone's face through case vignettes. And then we've actually tried to get clinicians who are involved in at the coalface into policy positions and advocacy positions at state and federal government. Actually, one of the people I'll have to tell you who's coming to our Cambridge meeting next year is Elizabeth Steiner Hayward. Some of you may know. She was a GP who became unwell and joined as a Democrat senator for the state of Oregon. In a true power of one story, she took on healthcare reform, and she adjusted the primary care spend to invest in community care organisations. They increased their spend enormously, and for every dollar they put in, she led the evaluation that showed $13 in secondary care spending saved. And she really shook up from a clinician to politician policy level back to the grassroots again, the way people view things. So I think industrial reaction and rattling the sabre does get the concentration and focus of those who make policy, but the most powerful thing, I think, are voters. And we found at home when people started saying to their local member, I'm not going to vote for you unless you do something about the fact I can't see a GP anymore, that really got everyone's focus quite sharp.
Okay.
I hope that answers the question.
Thank you, Claire. So in terms of primary care reform, another question about the role of technology versus workforce. So to what extent do you think primary care reform might be more focused on advancing the use of technology and decreasing workforce expenditure? What are the
Yes, and look, it's the delicious question, isn't it? I think those who are in the helicopter are going, we just make it all digital and the problems all go away. We were all used to do digital banking. We just do digital health. But that fails to recognise that health is very personal. And I have a lot of patients who are busy. I mean, during COVID was classic, who are unable to get to the surgery, and they have episodic care requirements or quite obvious requirements that I'm able to meet digitally. There are others that would be a disaster if I didn't see them face to face. And some of them are very good at working out which is which. The others not so good. The digital front door, I think I've interviewed a lot of people who I think it's worked very well for their practice. Others just say it's been a disaster. It's opened up all this unmet demand and just really led to further resignations in their already scarce workforce. I recall Trish Greenhalgh's catch cry, which I've always taken to heart, which is meaningful use of technology, and the fact that implementing technology and allowing the technology to be the reason for the season is a very silly way to go. It needs to actually fit with the work pattern, and it needs to make access and the work easier for patient and service deliverer rather than add a whole lot more complexity. A lot of the interviews I've done recently have demonstrated just how challenging it is to implement digital initiatives, and the amount of training and downtime and restructure that's inherent in that, but also that every practice and every setting is different in the way they will utilise digital enablers. So I think, again, local flexibility and being able to choose a system that's going to work for you rather than something works really well for secondary care, but is never in a million years going to work for anyone else in the healthcare sector. And the other thing I'd love to say right now is, please just don't have a universal record and expect general practice or primary care to troll through 597 e-pages of hospitalisation. Meaningful use of technology means sharing a minimum quality and safety data set and being sure that we can quickly get across what our patients need, rather than massive megabytes of dump that will really just make a very stretched workforce overwhelmed or just not involved.
Thank you. Great answer. So we've got a whole range of the Q&A is on fire, lots of questions on lots of different things. So
Great.
Question from Brandon about the role of voluntary organisations and
Yes.
how you think they might be able to help develop primary care services, particularly in preventative care. And are you optimistic about that?
Yes, and when I said inclusive of all, I particularly mentioning voluntary organisations. They have enormous community clout, their hearts in offering the absolute best to their community, and they often get left out because they're smaller, but they're often, for particular wicked problems, much better placed than anyone else to do things like social prescribing, to find those people who are isolated and lonely and lock them in with some of the support that may be out there. They're wonderful for homeless patients in Australia, being able to give them regular continuity with organisations. No, they're critical. The primary care networks, I think, are a beginning in being able to do that joined up identification of all who are important in primary care, and primary health organisations in New Zealand were very expert at being able to quickly access the voluntary organisations locally. It has to be a local solution because that's the only way you can find those organisations often. And things like social prescribing, I think, are just critically important in trying to offer people the correct service for their problem.
Great stuff, thanks. So just to return to what we were saying before about workforce versus innovation, we just had a follow-up question about the downsides of using digital innovations in primary care. Just your reflections on that, please.
I think to sum it up in one, it's when they don't fit. So a number of people I've spoken to have had a digital application works very well for them, and then their requirement is they need to move to something that's a standard national requirement that just doesn't fit for their community or their population. I think it's really allowing that, having a national approach to what needs to be delivered. As one of my interviewees said, national guardrails or guide rails, but allowing local flexibility to deliver on those is really important. And I think allowing the community to decide the balance between digital and face-to-face. And finally, I think a lot of the messaging, again, let's beat up the media. I hope there's someone here from the media who will be able to defend the territory. But often it's portrayed as, well, we don't really want to see you, so we're going to give you digital instead. Whereas for a lot of people, digital, particularly if they're well known to the patient practice, their notes are there, it's easy to understand whether digital is going to meet their needs safely or not. I think it's a very real and very important and successful opportunity. I just think we need to sell it and message it appropriately with face-to-face and all the other opportunities to improve healthcare access.
Great, thank you. So question from Shabana Nagraj about thinking about maybe a bit about international comparison. So maybe can you think of a healthcare system where primary care clinicians are treated with equal respect to the kind of specialists in the hospitals, and what impact do you think that has on workforce retention in primary care and
yes
decisions?
So probably, I mean, and I'm not an expert in every single country in the world. I've probably, from the visits I've done, the works at conferences, etc., the Danish health system seems to have as close to equal standing between the primary and secondary care as any I know. But in general, and I gave the examples there, US, Canada, New Zealand, Australia, the UK, primary care is just not treated in any way equitably across the system. In Australia, primary care providers, whether they're doctors or nurses, are funded probably about 50% of the funding that goes elsewhere in the system. They're disrespected in terms of the development of policy. They're called up to develop policy documents, and I've been in that position now 6 times, and the same sort of policy and the same sort of really important agendas are put forward, but then they're disrespected by funding going elsewhere. The policies are just put somewhere in a corner. And I love the cover of our 10-year plan. Did anyone else notice? It's a drab navy and white when everyone else gets a beautiful coloured marketing and comms style cover to their report. I just think it's a universal problem, and turning the system around where there is equal standing and equal input and acknowledgement that really high quality primary care, as I said, takes such diagnostic skill to really reform the system efficiently. I think I'd just love us all to be promoting that. And again, another reason for our meeting in Cambridge next year is to pick everyone's good ideas about how we might move forward.
Excellent, thank you. So we've still got loads of questions. We've only got time for one more. So this is the last question, and then we'll start to wrap things up. But a question from Lorne Williamson, which is, do you think that increased specialisation and expertise is a threat to primary care, and what might be done to provide a holistic approach?
So I think it's a barrier and an enabler, because overwhelming the need for good generalism is really important in the system, particularly for older patients. I find that get splintered off to that subspecialty approach, and then all the subspecialties flick the patient around, and they see cardiology and then gastro, and then they see a litany of other people, when really a generalist approach is really important, grounded in their life and their environment. And often there are other problems that are not being dealt with, such as their early dementia. So I think having a generalist link and a really high quality generalism in the community that can coordinate and link all those appropriate people is the way to go forward, and not to allow people to fast track into a quaternary specialist, and then to actually get locked into that environment, and to have much better shared care between community providers of all ilk and secondary and specialty care. And it's the linkages and the business rules about how that functions that is really critical, and is dealt with very different ways in very different systems, but that's at the kernel of what's needed.
Brilliant, excellent, thank you very much. I think we need to draw things to a close. That we could carry on going on all afternoon, but given the number of questions, but thank you, Claire, for your really interesting talk, and for you've done very well fielding the broad range of questions coming from all sides. So thank you. Are there any final remarks or comments that you would like to make before we bring things to a close, please?
Thanks, Steve. And look, it's been an absolute delight, and just love the questions as well. Look, I've been in the business a long time. We are on a burning platform, and it really breaks my heart to see people missing out on high quality care now in a way that even 10 years ago was not at scale the way it is now. We really got to move forward. And I think coalition of people like this group here, the group that'll be here in Cambridge next year, we really need international momentum as well as national and then local momentum. And we need to be shaking the tree with everyone, with, politicians, the political class, executive, clinicians, everyone, and particularly getting some positive messaging out through the media around the people who've done great things against all odds, and why we can't actually scale that up. And they happen in all countries. It's just no one ever celebrates their success more broadly. So thank you very much, and hopefully see lots of you next year in Cambridge.
Thank you, Claire. So we'll draw things to a close. And thank you all for joining us this afternoon for what was an excellent talk. Just to say, the presentation has been recorded and will be made available, and you'll be told how to access it in due course. So thank you again for joining us, and thank you very much, Claire, for an excellent talk. Have a lovely afternoon, everybody, and hopefully see you all soon.
Thank you
very much.